Perfect. So thank you so much for joining today to hear me speak about addressing women's health in cystic fibrosis. My name is Traci Kazmerski. I am a pediatric pulmonologist and health services researcher at UPMC Children's Hospital in Pittsburgh, Pennsylvania in the United States. And I have no relationships to this presentation that are going to have any conflict of interest, but I do receive research grant support and I'm a consultant for the Cystic Fibrosis Foundation and also philanthropic research support from the Children's Hospital Foundation. I have a few more disclaimers. So I am a pulmonologist. I am not a sexual and reproductive health specialist. And I really have no desire to turn CF providers into sexual and reproductive health specialists or primary care providers. But my hope is that you can leave this talk with more knowledge on both the general and disease-specific sexual and reproductive health issues that women with CF face, and some skills and resources to address these concerns with your patients. So why do we care about women's health in particular in CF? And there really appears to be an important interplay between being female and having CF. And it's theorized that this is driven by the impact of female sex hormones, including estrogen and progesterone, and CF physiology, infection, inflammation, and then impaired mucociliary clearance. And we know that women with CF have worse CF morbidity and mortality compared to men. And this sex disparity has been observed across multiple domains, including life expectancy, a greater number of pulmonary exacerbations per year, differences related to the acquisition of certain bacteria, and diminished recovery to baseline lung function following pulmonary exacerbation treatments. In turning to survival in particular, there is good evidence that despite continued advances in the survival of all those with CF, women have continued to have a lower median survival compared to men. And this is while accounting for nutritional status, pulmonary function, and airway microbiology. So the graph here shows data from the CF US registry from 1995 to 2007. And you can see that women have a median age of survival on this graph at this point in time of 36 years, while men have a survival of 38.7 years. And this is again adjusted for disease factors that I mentioned before. So this data is already a little over 10 years old, and more recent data from this CF Canadian registry found that women were at higher risk of death before age 30 compared to men. But really after the age of 30, there were no significant differences by sex in terms of median survival. And as I mentioned, the extent to which these female sex hormones contribute to the gender gap is really unclear. Recently, Cristina Montemayor and colleagues from Johns Hopkins analyzed data gathered as part of the STOP2 pulmonary exacerbation trial. And they found that women were treated with longer courses of IV antibiotics compared to men and reported worse respiratory symptoms over time. And although both men and women had improved percent predicted FEV1, women appeared to recover that FEV1 slower than men. And really the extent to which this is being driven by differences in treatment of men versus women or innate differences in CF health and pulmonary physiology is really not yet known. And this is, further an illustration of the array of things that women with CF experience in regard to reproductive health. They experience delayed puberty or perceived delayed puberty compared to their peers, worsening CF symptoms during the menstrual cycle, increased yeast infections because they are treated with high levels of antibiotics very frequently, urinary incontinence, which is thought to be due to weakness of the pelvic floor musculature and thus stress incontinence, sexual functioning concerns, specifically coughing during sex, issues with contraceptive choice, concerns around fertility, pregnancy, and whether or not to be a parent. And I always like to frame things from the viewpoint of a person with CF. And a few years ago, I did an interview with a woman with CF who was 20 at the time. And I'll just read her words to you. So it's always like you just don't talk about it. It's one of those things that's left to the side. It's that healthcare providers feel it's not as important as everything else, but sometimes it is. I mean, it wasn't life or death threatening, but it could have changed my life a lot. I'm a firm believer in the fact that you never know until you ask. So that's what we did. A few years ago, we did a 5-site survey at US CF centers of women with CF aged 15 to 24 years. And we found that of those 188 women that we surveyed, about a third perceived that they had pubertal delay compared to their peers. 1 out of 6 experienced urinary incontinence once a month or more. Nearly half had experienced a yeast infection. And 1 out of 3 experienced coughing during or after sex half the time or more. Furthermore, on a validated screen for sexual functioning concerns, 1 out of 6 of these young women were experiencing sexual dysfunction. We also found that adolescent and young adult women with CF were having sex at the same rates with the same number of partners and around the same time of sexual debut as US teens and young adults without CF. However, they were significantly less likely to have ever been tested for sexually transmitted infections, to have ever used birth control or contraception, or to have ever been pregnant. More recently, we repeated this work with adult women with CF, age 25 and older. And this data is still under analysis, but we presented this work at the North American CF Society conference this past October. And of the 438 women who had been surveyed at that time, we found that 1 out of 4 experienced worsening CF symptoms during their menstrual cycle. And this was usually right before a woman's period or during her period. Nearly half had experienced urinary incontinence once a month or more. 28% were experiencing yeast infections several times a year or more. And a little over half, again, had coughing during or after sex half the time or more. Similar to the group of young women that we had surveyed, adult women with CF were also having sex at the same rates with the same number of partners as their non-CF peers. But again, we're significantly less likely to have ever been tested for sexually transmitted infections in the past year compared to the general population, to receive a pap smear or pelvic exam in the past year, to be currently using contraception, or to have ever been pregnant. Furthermore, 51% of the women that we surveyed who had experienced a pregnancy had no preconception counseling. And 8% of those who had a live birth had no prenatal care. Some concerning statistics that we found. And further on the topic of accessing sexual and reproductive health care, over the years, we've done interviews or focus groups with over 70 women with CF in the US. And these are some of the quotes that they've shared with us. And most of these conversations that we've had with women really center along this idea that CF providers are their go-to when they want to talk about anything health-related. And as one woman put, because I feel even when I'm at another doctor, it's all really CF-related. But they also felt that this was something that CF providers just weren't talking about. And they often felt like a middleman in this aspect of their care and as a go-between between their CF team and a women's health provider. And I think it's very important to highlight from the 2 surveys that I had mentioned, we found that nearly 4 out of 5 young women and nearly half of adult women with CF intended to have future children. So as we are improving with our therapies and treatment of people with CF, more people are recognizing and hopefully going to realize their reproductive health goals, which may include parenthood. Which brings me to the next part of the talk, which is what we as CF providers think, and then what we're doing in relation to sexual and reproductive health. So several years ago, we conducted a US provider survey that really demonstrated that the majority of primary CF providers felt that sexual and reproductive health was important for young women with CF and should be standardized in the CF care model. However, we uncovered major discrepancies between how important providers felt these topics were to discuss and then how often they routinely address them with women with CF. For instance, 90% of participants felt it was very important to talk about pregnancy, while only 63% actually did so. And these discrepancies were much more prominent in pediatric providers compared to our adult colleagues. A few years later, we conducted a survey of interprofessional CF providers, so including all members of the CF care team, in regards to their educational needs around sexual and reproductive health. Of the 523 folks that completed the survey, half reported that they had comfort responding to sexual and reproductive health concerns of young women with CF. Only a third were comfortable, though, asking the right questions and were confident taking a sexual history. And again, a little under a third were comfortable with their current sexual and reproductive health knowledge for this population. This group really did desire further training, and the kind of top 5 topics that they were interested in were around pregnancy and parenthood, sexual functioning concerns, urinary incontinence, intimate partner violence, or taking a sexual history. 2/3 felt that having a connection to sexual and reproductive health specialists who were familiar with CF would really facilitate this care. And a third desired sexual and reproductive health educational materials for providers to view really at the point of care or through online case-based learning. So a real need for more training and educational strategies for the CF community around this aspect of care. So really, where do we go and how do we go forward here? This is an extremely simplistic view of how a patient and provider interact, and then the healthcare system really surrounding them. But I'm going to use this simple graphic to explain the next part of the talk. So really thinking about the patient, I think 2 aspects that I want to highlight are the availability of educational resources specific to sexual and reproductive health for women with CF, and then reproductive health decision aids as a tool. So there are a variety of very good online and freely accessible resources for women with CF to engage with around reproductive health. The Center for Young Women's Health is a website run by Boston Children's Hospital. And in partnership with them, we created 13 CF-specific health guides with the content and topics and language, importantly, directed by women with CF, as well as their families and multidisciplinary providers. And this is the website for these resources. And it is really, these are focused on young women aged 12 to 26, so adolescents and young adults, and they're written to that grade level for reading and literacy and addressing topics that are important for young women. A similar resource targeted to younger women with CF was put out by an organization in Australia, and this website is called SPIL. This is a fantastic resource that really gives frequently asked questions and facts about reproductive health for both men and women, and also highlights these issues by very well done videos with patients with CF. And this is their website there. You know, for adult women with CF, the US Cystic Fibrosis Foundation has a lot of content on their website around family planning and parenting, as well as around fertility and other reproductive health concerns. And then the CF Trust in the United Kingdom also has similar content online around fertility in CF, as well as a variety of reproductive health issues. And then finally, we've been working on a reproductive planning tool or decision aid for women with cystic fibrosis. Often educational resources are very flat-facing, where the people who are using them really can walk through them at their own pace, kind of browse things, and it doesn't feel like a tailored experience. Decision aids often will walk a user through a decision and having them interact with the tool and inputting facts about themselves, feelings that they're having, concerns that they may have. We work together with a group of stakeholders to do some formative research, as well as develop this tool called My Voice CF, which is really planned for pilot testing for feasibility to see if it works within the CF care model in the winter of spring of 2021. And the hope is that if this does indeed prove feasible and acceptable to women with CF, we'll be able to test to see if it impacts patient-provider communication around these tools, shared decision-making around reproductive health, or longer-term CF health outcomes or women's health outcomes, including contraceptive use, preconception planning, et cetera, et cetera. So stay tuned for results of that pilot and hope for future studies. I'm going to go back to this very simple graphic, and we'll go to the provider box now. And I've mentioned many times that this is very simple. And you know, truly the provider is much more complicated than just one person. It's a primary care provider, the CF team, or the women's health team. And I think it's important to consider that all of those members have a place in the aspect of reproductive health with women with CF. So really, how do we create this space? I want to pause here from one of the first interview studies that we did with patients with CF. They really told us that educational resources around reproductive health were needed and necessary, but they said that those in and of themselves were not adequate, and they really desired them to be paired with discussions around reproductive health with their CF providers. And we found this in our interviews, and Susan Sawyer, who did some of the landmark work around reproductive health and CF from Australia, similarly found such themes. And women have told us through surveys and qualitative work that they want to speak alone with their CF team, and they want CF providers to be the ones to initiate these conversations. Often this pairs well with self-visits with teen or young adult patients without their parents or family members in the room to allow for confidential discussion of these issues in a way that patients feel empowered and increase their self-efficacy to have these talks. To really underline this, in the recent survey of adult women that we just completed, we found that 41% of those women do not identify a primary care provider at all, and that 84% believe that their CF doctor is their main physician. So despite the fact that we are not sexual and reproductive health specialists, it is incumbent upon us in the eyes of many of our patients to be the one to at least open the door to these discussions and connect people to the right care. An organization in the US called the Power to Decide really came up with this idea of one key question. And the hope is this provides a framework for healthcare providers to support women age 18 to 50 by routinely asking them, would you like to become pregnant in the next year? And the thought is that one question, when asked in an encounter, can open the door for discussion on this issue and connecting people to the care that they need. I think the real question is this the right question for cystic fibrosis? And I would argue that because there are many ways to build a family, and often people with cystic fibrosis as a chronic genetic disease are interested in exploring adoption or surrogacy or foster care as a path to parenthood. So I would advocate to ask, would you like to become a parent in the next year? And as a pediatrician by training, I think that when dealing with younger patients, this can feel very odd to ask a 16-year-old, would you like to become a parent in the next year? Because the answer is probably no. But it doesn't mean that they haven't thought about it. So often I'll ask my younger patients, would you ever like to become a parent? And just to follow this out, by asking if someone would like to become a parent in the next year or ever, there's really 4 valid answers that someone can give you. The first is yes. And then I think the question becomes, if it's a woman in front of you, would you like to become pregnant? And if the answer is yes, really connecting them to preconception care, or if the answer is no, exploring the paths to parenthood that she is interested in. They may say no, and if they're sexually active, really connecting them with appropriate contraceptive counseling and care is the next best step. And then finally, they can say, I'm not sure, or express ambivalence, saying I'm okay either way. And it's really important for us as CF physicians and care teams to support them in that decision. So one final turn back to this graphic and a focus on the healthcare system. And I'm really going to focus on collaborations and smarter systems. So I once had a provider tell me in an interview on this topic that they don't ask too many questions because they don't know how to get out of that rabbit hole. And another provider shared that they don't quite know how to close Pandora's box once they open it with diving into these topics. And I think one way out of the rabbit hole is to really identify partners that you as a CF team or physician can have a dialogue with. And whether this is primary care providers, family planning or gynecologists, adolescent medicine, maternal fetal medicine for high-risk pregnancies, genetic counseling, or again, urogynecology for urinary incontinence. There's also this idea to embed women's health directly into CF care. So a group in France did a recent evaluation of an on-site gynecological consultation within their CF adult center. And this was a single center study where they followed reproductive health outcomes for women who were seen in this way for several years after implementation. And they found pretty remarkable increases in contraceptive use, long-acting reversible contraceptive use, so intrauterine devices or implants, a 30% increase in cervical cancer screening, and then just a 17% increase in access to women's healthcare in general. And I think this is really interesting. We embedded a question about this in our survey, and we found that nearly 50% of the adult women that we surveyed with CF were interested in exploring a model like this to have a women's healthcare provider as part of routine CF care. I think other systems level changes deserve some attention as well. One being clinical decision support tools in the electronic medical record. And by that, I mean when seeing a patient who's of reproductive age, getting alerts to address reproductive health, contraceptive use, any concerns that the patient may have, and then further to connect them with resources and order simple tests such as pregnancy testing or referrals within the system may be a good way forward. And I think the ability to refer quickly to a women's health provider is really key here, and to have communication options to optimize collaborating with those teams, and whether that be a standing meeting between the CF Center and women's health providers, or other ways to do this. And then finally, I think in the era of COVID-19, all of us have been experiencing increased use of telehealth or virtual care for our CF patients. And I think that telehealth as a way to improve access to specific women's healthcare providers, preconception counseling, contraceptive counseling in general, is really something that we can explore and expand upon even after COVID-19 has passed. I think, too, it is very vital that we consider all such changes in the context of how I refer to it as the changing face of CF. With highly effective modulators here for 90% of people with CF, I think how we are going to take care of people and how often we're going to see them in person and how sick they are when we do see them is going to change. And I think that, you know, we really want to continue to innovate generally how we're going to change our care system for people with CF in light of this, and specifically change how we deliver reproductive health to people when they need it. And I'll just again say, please stay tuned. As I mentioned, we did a 10-site, very broad survey on women's health for adults, and this is really under analysis, including, you know, a lot of the women that we surveyed were much older, and some had reached menopause. So we do have data on what menopause is going to look like, or it has looked like for women who've reached it in CF, which I think is a new frontier truly. As people are living longer and healthier lives. The CF Foundation is sponsoring several studies specific to women's health that I know of and that I'll highlight here. One is a really comprehensive look at pregnancy in CF and maternal fetal outcomes, including the use of highly effective modulators during pregnancy. This is called the Mayflower Study. And the retrospective arm is really ongoing for this, and a prospective arm is in the planning stages. Similarly, there is a study on contraception use in CF and health outcomes that is going to leverage US registry data as well as patient survey data around their contraceptive use. There's more work that's being done regarding female sex hormones and CF health outcomes out of Johns Hopkins. We have a family planning specialist who's looking at CFTR modulators and their impact on cervical mucus, specifically if the consistency and quality of cervical mucus is changing and maybe fertility is improving due to that with modulator use. A urogynecologist at the University of Pittsburgh is going to be looking at the experiences of women related to urinary incontinence, as well as the efficacy and feasibility of different treatment modalities to treat incontinence in this population. And then finally, parenthood in CF is increasingly becoming a question for many of our patients and families. And the outcomes of people who become parents in regards to their pulmonary health, their mental health, adherence, and so forth, really do need to be explored, and we are planning a large multi-center study for that. So that's what I know we have going on in the United States, and I have no doubt that our colleagues in Australia, the United Kingdom and Europe, as well as around the world, are looking at this as well and thinking through how we can improve reproductive health care for people with CF. This is Julia Child, and she was an American chef who had a TV show. And this is kind of what it looked like underneath her table. So she is on camera here. And you can imagine that all you're seeing is her head and kind of upper body, but really there's lots of people behind the scenes who make her look polished and help things go. I have many people behind the counter, not the least of which is the Cystic Fibrosis Foundation, who I mentioned has really invested in women's health and has sponsored a new women's health research working group, of which I'm a member and whose members are listed here. And these are brilliant women who I learn from every single day. I want to acknowledge my research coordinator, Olivia Stransky, who truly I could not do anything without, and who's also very brilliant. And then most importantly, our patient partners and women with CF who have lent their voices to this work and really helped develop a lot of the interventions that we're looking at and formulate some of these important research questions that are directly affecting their lives. So again, I apologize that I'm not joining you in person, but this is my email address. If you have any questions or would really like to start a dialogue, I would welcome any contact that you want to do, and please reach out to me with questions and comments. And again, I will stop there, and thank you again so much for the opportunity to highlight women's health in cystic fibrosis in this modern era of care. Thank you.